AIOS, and I'm here to talk to you about a 13-year-old female child who was diagnosed with TB meningitis on anti-TB therapy and presented to us with acute diminution of vision in both eyes. So, the diminution of vision in CNS TB can stem from tuberculous optic neuritis, posterior visual pathway involvement, paradoxical reaction to ATT, or ethambutol toxicity. We had to narrow it down, and we were left with two causes. Could the TB be affecting her visual pathway, or ethambutol, the drug that's supposed to save her, harming her? How do we decide on management without compromising her TB treatment or risking irreversible blindness? So she was started on ATT in April 2023 and was stable on it until June 2023 when she developed pain in left eye which increased with eye movements. The next day she developed blurring of vision in both eyes, more in the left side. She was taken to a local hospital and on the way she developed multiple episodes of seizures. Examination revealed an asymmetric vision loss, 612 in the right eye, 660 in the left eye, loss of color vision, sluggish pupil, and fundoscopy revealed nasal margin blurring in the left eye. Perimetry revealed incomplete temporal hemianopia in the right and generalized constriction of fields with foveal involvement in the left eye. MRI was a turning point which showed T2 hyperintensities in midbrain and pons, and contrast revealed left optic nerve enhancement along with temporoparietal leptomeningeal enhancement. So the diagnosis was clear, TB optic neuritis. But could ethambutol be a silent accomplice? We didn't want to gamble too much with vision, so we stopped ethambutol and levofloxacin was started for TB cover. She was also started on IV methylprednisolone pulse therapy. After 1 week, her vision improved to 6/6. After 6 months, she regained complete vision and color vision. She was found to tolerate levofloxacin well, and hence she was continued on levofloxacin. What is unique about my case is the atypical overlap of symptoms and the choice as to whether to stop ethambutol or not. So, was stopping ethambutol the right choice? Especially when it is the first-line drug of TB, and stopping it can risk treatment failure. On the other hand, ethambutol toxicity can lead to irreversible vision loss. Misdiagnosis can lead to unnecessary ethambutol cessation and delayed anti-inflammatory therapy. I would like to leave you with the following messages. Imaging is key. Ethambutol may not always be guilty, but if doubt persists, don't hesitate to stop it. When a patient is being started on ATT, always monitor vision very closely before starting ATT and while on it. Steroids can save sight, but only when inflammation is confirmed. So when a case like this presents to you, always think if it's a disease, the drug, or can it be both? Thank you.
Thank
So
you.
what is the basic protocol of eye evaluation while patient is on ethambutol?
Sorry,
So
ma'am?
how frequent? If patient is on ethambutol, what is the main protocol of following up those patients?
So we have to do a baseline evaluation and every 2 months. So we'll check the
So
vision.
there you have written, I think, 1 month
1 month.
evaluation. Yeah, so it's basically 2 months.
2 months.
So what you do on these 2 monthly visits?
So we have to do the basic vision, color vision, and better if we do an HFA perimetry, and OCT RNFL is like the best.
So it is in the protocol or it's like your choice to do the perimetry or not?
It's in the protocol. If we suspect it, it has to be done.
Yes. Okay, nice presentation. Dr. Sanjana.
So baseline, at least color vision and contrast you can do, and of course OCT can help. It can even detect early or pre-perimetric kind of an involvement. But of course availability is there. But basic, at least vision, color vision, and contrast. These three things should be done. Color vision is kind of affected the earliest, which is there. So again, interesting case. So what are the ways in which a tuberculosis can affect the optic nerve?
So it can have, first optic neuritis. It can affect anything along the visual pathway, including chiasmatic lesion, retrochiasmatic lesion.
That is, you are saying the location. I'm telling you what mechanisms, what are the ways in which tuberculosis can affect the optic nerve.
Tuberculosis can be there.
Tuberculosis. So tuberculosis, what do they do? What will it do?
So that could be That would be a neurosurgical approach.
So it will be a compressive, okay? So one is inflammation, which you are saying direct invasion of the optic nerve due to inflammation or due to direct invasion. These are two different things, okay? It could be a inflammatory, like a response to the tubercular antigen, which is like an antibody response, could be one thing. Then it could be direct invasion. It could be compression from the tuberculomas, and any other ways that it can affect. So as a result of raised intracranial pressure also, and the effect of treatment also. Okay, that is the ethambutol toxicity. Any other drug can cause toxicity apart from ethambutol? Any other anti-tubercular drug?
Isoniazid can also.
Very good. So even isoniazid can cause, okay? So it is important to differentiate amongst all of these when you are having a patient in front of you who is a known TB, plus that's especially a cerebral TB, and then presenting to you with a visual loss. Okay, in your case it was, there was a sudden loss, there was a disc edema which was there, so it was more in favor of an inflammatory or a direct invasion, although with ethambutol toxicity also sometimes an optic neuritis kind of a picture is there, but the imaging is a very subtle imaging. There will not be like, so the full length involvement, and that this actually shows a direct invasion or inflammatory kind of a thing where IVMP and continuing the medications would be there. Okay, thank you.